Good evening, welcome, and thank you for attending tonight's Head of Cancer Lecture Series sponsored by the Allegheny Health Network Cancer Institutes. My name is Michelle Studnicki, and I'm one of the program coordinators for the Cancer Institute. There are a few housekeeping items we need to go through before we start tonight. During the presentation, all participants can type questions into the chat and Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Our topic tonight is Her Best Defense: Modern Advances to Defend Against, Detect, and Defeat the Disease. As many of you are aware, October is Breast Cancer Awareness Month, and we are incredibly fortunate and excited to have two remarkable experts join us this evening, Dr. Suzie Coopey and Dr. Eirwen Miller. It's a true honor to welcome them. And before we get started, I'd like to take a moment to properly introduce these distinguished physicians and offer you a glimpse into the outstanding, impactful work they're doing in the field of breast cancer and right here at Allegheny Health Network. Dr. Coopey is she is the breast surgery division chief for Allegheny Health Network and the chair of the breast cancer program at the AHN Cancer Institute. She earned her Doctor of Medicine degree from The Ohio State University College of Medicine and completed her residency at the Cleveland Clinic and pursued a fellowship at Massachusetts General Hospital, Bingham and Women's Dana-Farber Cancer Institute. Dr. Coopey also holds an appointment as the Associate Professor of Surgery at Drexel University College of Medicine. Her expertise encompasses nipple-sparing mastectomies, management of high-risk lesions, lumpectomy margins, and the implementation of enhanced recovery after surgery, ERAS, protocols, which focus on reducing opioid use, pain, nausea, and hospital stays. Board certified by the American Board of Surgery, Dr. Coopey has a strong background in clinical research and has co-authored numerous peer-reviewed articles. Dr. Eirwen Miller. Dr. Miller is a distinguished gynecological oncologist specializing in ovarian, uterine, cervical, and vulvovaginal cancers. She earned her medical degree from Wayne State University of Medicine in Detroit, Michigan, followed by a residency in obstetrics and gynecology at the UPMC Magee Women's Hospital in Pittsburgh. Dr. Miller then completed a prestigious gynecological oncology fellowship at Albert Einstein College of Medicine / Montefiore Medical Center in New York in 2017. For the past 8 years, Dr. Miller has been a vital part of the Division of Gynecological Oncology at the Allegheny Health Network, West Penn Hospital. In this role, she provides comprehensive, full spectrum care to women with gynecological malignancies encompassing surgery, chemotherapy, survivorship programs, and end-of-life care. Beyond her significant clinical commitments, she also serves as the Gynecologic Oncology Fellowship Program Director and the Quality Officer for the Women's Institute. Dr. Miller's dedication extends to research, evidenced by over 30 peer-reviewed publications. She has also served with distinction as the site principal investigator at Allegheny Health Network for multiple practice-changing clinical trials, contributing significantly to the advancement in the field. Welcome, Dr. Coopey and Dr. Miller. And I will hand this over to Dr. Miller.
Hi, thank you, Michelle. I'm going to go first. In honor of Breast Cancer Awareness Month, I decided to change my talk to Her Breast Defense: Modern Advances to Defend Against, Detect, and Defeat the Disease. For the talk today, I'm going to go over breast cancer screening recommendations, a little bit about breast cancer risk assessment, options for supplemental screening for those that are deemed to be high risk for breast cancer, and those with dense breast tissue, recommendations for genetic testing, when people will consider risk reducing or prophylactic mastectomies, some lifestyle modifications to reduce breast cancer risk, and then multidisciplinary care after a breast cancer diagnosis. So breast cancer screening recommendations, very important in the month of October and always. most people really recommend starting at age 40 and getting the mammogram annually every year. There's been some changing guidelines over the years, with some recommending 45 or 50, some recommending annual or every other year, but it's best to do it at age 40 and every single year. There's no official stopping age for mammograms. Most people say get it until age 75. But healthy 75-year-olds can continue to get them for many, many years. And we have women even into their 80s and early 90s still getting mammograms, because if we found something, they're healthy enough to undergo treatment and would choose to get treatment. We know that yearly mammography beginning at 40 saves the most lives. 1/3 of breast cancers in Black, Hispanic, and Asian women, and 1/4 of breast cancers in white women actually occur under the age of 50. So we would miss a lot of cancers if we started screening at the age of 50 instead of the age of 40. When we screen earlier and regularly, we find breast cancer at earlier stages when the tumor is likely to be smaller, less likely to have spread to the lymph nodes, and it's more curable, less likely to have distant spread. When we catch it earlier, treatments are less likely to need chemotherapy, shorter courses of radiation. Since the introduction of screening mammography regularly since the 1990s, we've had a 40% reduction in breast cancer mortality. So I know that no one really likes to get screening mammograms, but screening mammograms actually work. And they work significantly well to find breast cancers early. There's a lot of talk about breast density, and a lot of times now when you get your mammogram, you'll get a letter talking about your breast density. This is just a measure of how much fibroglandular breast tissue is within the breast compared to the amount of fatty tissue. Fibroglandular breast tissue looks white on the mammogram, while the fatty tissue looks dark on the mammogram. Breast density has been reported on screening mammograms since 2014 in the state of Pennsylvania, and the FDA now requires nationwide that mammography facilities notify patients about their breast density. So you will get an official letter that states if your breasts are dense or not dense. This is just a little demonstration of what breast density looks like. There are 4 categories of breast density, from category A, which is almost entirely fatty, all the way up to category D, which is extremely dense. And you can see how the amount of white tissue increases as the density goes up. When we talk about dense breast tissue, it's category C, which are heterogeneously dense, and category D, which is extremely dense. In the United States, this makes up 50% of women, so it's not an uncommon thing to have dense breast tissue. The problem with dense breast tissue is that cancer also looks white on a mammogram. So when you have a lot of density, it can make it harder to see a very small cancer. With the introduction of digital breast tomosynthesis, or 3D mammography, we've had improvement in the ability to see cancer in dense breasts. If you look at the photos to the right, the first picture on the left is an example of a 2D mammogram, or flat mammogram, versus a 3D mammogram. And you can see on the 3D mammogram, when we can scroll layer by layer through the tissue, that a small mass became apparent on this mammogram that was otherwise hidden in that dense tissue. 3D mammography is now standard of care throughout all of AHN for anyone coming in for a mammogram. We also sometimes will add ultrasound or MRI for extra screening for dense breast tissue or additional risk factors, which will make people at higher risk. We do a lot with risk assessment now. One of the most common risk assessment models is something called the Tyrer-Cuzick model. This is a risk assessment tool that estimates the lifetime risk of breast cancer. The average woman has a lifetime risk of 1 in 8, or about 12%. Anything that's greater than 20% is considered high risk, and that's when you'll meet criteria for additional screening. Throughout AHN, we do the Tyrer-Cuzick model at the second mammogram that a woman has, because at the first mammogram, that's when we'll find out what the breast density is. With the mammogram report, your ordering doctor will get a report, and if you're above that 20% lifetime risk, it'll actually be flagged and highlighted in yellow that they calculated your risk and you're above 20%, and to consider additional screening. The Tyrer-Cuzick score is made up of several different things. Age, height, and weight, breast density plays a big factor. Whether or not there's been a history of breast biopsy and the results of those biopsies, also a personal or family history of breast or ovarian cancer, any hormone therapy use, whether or not you've got Ashkenazi Jewish heritage, and then hormonal risk factors like age of first period, age of first birth, and age of menopause. Supplemental screening with breast MRI should be considered when there is a lifetime risk greater than 20%. It's an imaging test that does not use radiation, but instead uses magnetic fields. It does use an IV contrast dye, and then the breast tissue is evaluated based on how the tissues are taking up the contrast. Pros of the MRI is that it is more accurate than the mammogram. It can definitely catch more breast cancers, but there are a few cons to the MRI. Because it's so sensitive, you can have more false positives where things light up that we then have to work up with additional imaging, sometimes biopsies. Everyone wants to know, is MRI a replacement for the mammogram? And unfortunately, it's not. They're complementary tests, but they don't replace one another. The mammogram actually does a better job at finding calcifications, whereas the MRI can miss calcifications about 30% of the time. And oftentimes calcifications are the first sign that there's something going on, either high risk or early cancer. MRI is also more expensive. And it takes longer, and for people that are claustrophobic, it can be a difficult test. This is just an example of a patient that had a screening breast MRI, which found a small 9mm cancer. And she had dense breast tissue and had stage 1 cancer found very, very early. In the state of Pennsylvania, there's actually a law that was passed saying that insurance has to cover supplemental screening with breast MRI and ultrasound for these risk factors: personal history of breast cancer, family history of breast cancer, personal history of abnormal breast screenings, extremely dense breast tissue, or heterogeneously dense breast tissue with an additional risk factor. And one of those is that lifetime risk greater than 20%. Or if you've had a diagnosis of a gene mutation that increases your risk of breast cancer. The law also states that women should have access to genetic testing and genetic counseling based on family history and increased risk. So who qualifies for genetic testing? Since 2019, the American Society of Breast Surgeons recommends that anyone that's been diagnosed with a breast cancer should be offered genetic testing, and it should be available regardless of family history. Patients that have had previous genetic testing prior to 2014 should consider having updated testing, because now we test for additional breast cancer genes. There are some NCCN guidelines, which I'll talk about next, for who will qualify that hasn't had a history of breast cancer, but a family history. And then I just want to stress that if you do have genetic testing, they sometimes will find things that are not positive or negative, but something called variants of uncertain significance, or VUS. These are DNA sequences that are not clinically actionable. And in fact, most of these are later reclassified as benign. And so we don't really recommend strongly for things like preventative mastectomies for VUSs. So if you have never had a breast cancer diagnosis, but you have a strong family history, such as a first-degree relative with a known gene mutation, a family history of breast cancer, younger than age of 50, a family history of triple negative breast cancer, family history of bilateral breast cancer, which is breast cancer in both breasts, family history of male breast cancer, family history of invasive lobular breast cancer and diffuse gastric cancer, or a family history of ovarian, pancreatic, or metastatic high-risk prostate cancers, or if you have Ashkenazi Jewish descent. All of these things can increase your likelihood of having a gene mutation. So why do people consider doing genetic testing? There's a few downstream benefits. One is you can then qualify for supplemental screening with breast MRI, which can detect cancer at an earlier stage. There are also some risk-reducing medications that can lower your risk if you're found to be at high risk. Drugs like tamoxifen, raloxifene, and aromatase inhibitors. For some, if their risk is high enough, they may consider doing risk-reducing or preventative mastectomies, or having their ovaries removed, which Dr. Miller will talk about later. Also, if they have a diagnosis of breast cancer, there are certain drugs like PARP inhibitors that may be recommended specifically for BRCA mutation carriers, which would not be available otherwise. And it also helps to inform your family members of their risk, because if you have a gene mutation, your first-degree relatives, like your parents, your children, your siblings, they'll also have a 50% risk of potentially having the same gene mutation. There are certain genes that if you test positive for mutations, you may consider doing preventative or risk-reducing mastectomies. According to the most recent NCCN guidelines, which is the National Comprehensive Cancer Network, they recommend that women consider risk-reducing or prophylactic mastectomy for BRCA1 mutations, BRCA2 mutations, CDH1 mutations, PALB2, PTEN, TP53, and STK11. There are other genes that, the evidence isn't strong enough to recommend risk-reducing mastectomies, but if you have one of these mutations and also a strong family history of breast cancer, it is a reasonable thing to consider. So an ATM mutation, BARD1, CHEK2, NF1, RAD51C, and RAD51D. I am going to touch just a little bit on lifestyle modifications. I won't spend a whole lot of time here, but just as a good reminder, in terms of breast cancer risk reduction for alcohol, best not to drink at all or limit alcohol to no more than 1 drink per day. Best not to smoke or vape. For diet, follow healthy eating pattern, limit processed foods, and exercise, be physically active, limit sedentary behavior. We know that moderate alcohol intake, more than 1 or 2 drinks per day, is associated with an increased risk of breast cancer. I always like to remind everyone what a standard drink is, because it's actually a pretty small amount. 1.5 ounces of liquor, 5 ounces of wine, 12 ounces of beer. We know that the ethanol in alcohol is oxidized to acetaldehyde, which itself is carcinogenic. We also know that tobacco has about 20 known breast carcinogens, and that in 2019, they've attributed about 5% of breast cancer-related deaths to tobacco. The good news is, as people have stopped smoking, breast cancer deaths associated with tobacco have gone down over the last 30 years. Just wanted to push the New American plate, which is in contrast to the Old American plate, which was heavy on meat and starchy foods like potatoes. Now it's more fruits, veggies, whole grains, beans should occupy 2/3 of your dinner plate, and only about 1/3 of the plate should be animal protein. We also know that increased physical activity decreases breast cancer risk in everyone. It lowers circulating levels of estrogens and androgens, especially in postmenopausal women, reduces systemic inflammation, and prevents weight gain, lowers risk of excess fatty tissue, which can create a pro-carcinogenic environment. Exercise recommendations, probably you've all heard this before, 150 to 300 minutes of moderate physical activity per week, or 75 to 150 minutes of vigorous physical activity per week or a combination of the two. And it just a few slides at the end, just what if you do everything right and still get breast cancer? There's a lot of resources available now to guide you through a diagnosis. One is you'll be connected very quickly to a nurse navigator that will help streamline important appointments and also just explain like what comes next. They'll get you appointments. You'll find a great team. Typically, you'll see a breast surgeon first who will explain the diagnosis, next steps, which may include these things like breast MRI, genetic testing. Breast cancer care is multidisciplinary. It often involves a surgeon, medical oncologist, radiation oncologist, sometimes a plastic surgeon, and everyone has a different treatment plan, and the team kind of figures out this plan together. If you need more social support, we now have a patient ambassador program. We've got an exercise oncology program to help you with the exercise and the nutrition component, and integrative oncology as well. Lots of resources are available, and we're happy to get anyone connected with the patient ambassador program, where you can connect with a person who's been through it already, and they can just give you support and just be an ear to listen and get you connected with resources you may need. The exercise oncology program is definitely a highlight of the AHN cancer program, where you can enroll on exercise clinical trials, 12-week programs, and really do a lot of weight training, nutrition, which improves your body composition, your strength, all of that. And we're hoping long-term it'll show that cancer outcomes are improved as well. We've got something called integrative oncology, which connects you with massage, Reiki, acupuncture, programs that help you learn to cook and eat better, and movement and breathing classes, all complementary. And just because it's Breast Cancer Awareness Month, I need to put a plug in for our new and expanded walk-in mammogram program. So many of our facilities now are offering daily walk-ins Monday through Friday from 7:30 to 11:30 a.m. These are West Penn, Allegheny General, North Fayette, Jefferson, the Fox Chapel Waterworks location, Waterfront, Uniontown, and Brentwood. So you can walk in now with no appointment needed. So thank you very much for your attention. I'm going to pass it over to Dr. Miller.
Hey, thank you, Dr. Coopey, for the review on breast cancer. My portion of the talk tonight is looking at gynecologic malignancies. Hold on, let's see, there we go. We're going to talk tonight about, just what GYN oncology is, the types of cancer that we care for in GYN oncology, the symptoms of these cancer, opportunities for screening, and what some resources are going forward. So GYN cancers are a heterogeneous group of cancers. It's actually 5 distinct disease sites. And each of these really has its own treatment paradigm, its own unique symptoms, its own unique opportunities for prevention. So talking about GYN malignancies in 20 to 25 minutes is a big feat. My goal tonight is just education and some opportunities to initiate a conversation with your physician about what GYN malignancies are, and give an introduction into what resources may exist should you be diagnosed with a GYN cancer. So the female reproductive tract is made up of a variety of different organs. The one that is most well known is the uterus. In the diagram, the uterus is that central organ, oval in shape. And that is, what women refer to as the womb, or where a fetus grows when you're pregnant. There's 2 unique different types of cancer that we can see arise from the uterus. We can see endometrial cancers that arise from that thin pink lining on the inside of the uterus. That's the part of the uterus that menstruates every month when a woman has a menstrual cycle. Outside of that, there's a thick outer shell of muscle, and cancers that arise from that portion of the uterus are treated very differently and present very differently. And those malignancies are called sarcomas. Outside of the uterus, we have the ovaries and the fallopian tubes. They are distinct organs, but their cancers look, behave, and are treated basically the same. There's also a type of cancer called a primary peritoneal cancer that lives in the family with ovary and fallopian tube cancer. Those malignancies arise actually from the lining of the abdomen. This lining covers all of our organs on the inside of the abdominal cavity. And those cancers similarly appear the same and are diagnosed and treated the same as ovarian and fallopian tube cancers. The lowest part of the uterus, the exit from the uterus into the vagina, is called the cervix. That type of cancer is distinct from uterine cancer and its risk factors and its treatment paradigms. Beyond the cervix, we have the vagina, which is the canal that exits the body out onto what we call the vulva or the external genitalia. And there is much overlap between our treatment paradigms for cervical cancer, vaginal cancer, and vulvar cancer. Beyond these, in the scope of GYN oncology that we're not going to talk much about today, but on occasion we do see placental cancers in women that have had prior pregnancies, either recently or remote. And these are called gestational trophoblastic disease. We're not going to talk much about those tonight. So what is GYN oncology? A GYN oncologist is a physician that specializes in the diagnosis and management of women with cancers arising from the reproductive system. As Michelle nicely introduced, a GYN oncologist will initially complete a residency in an OBGYN training program and then go on to complete another 3 to 4 years of a GYN oncology fellowship program. And during the fellowship time, there is an in-depth education about surgery, about chemotherapy, and radiation, as well as research methodologies to lead the field in innovation and advancements of technology. So we're going to start by talking about symptoms. The symptoms of these cancers are really dependent on the site of origin of the cancer, but certainly a change in any of these symptoms is worthwhile to discuss with your physician. The most common symptom that we see for endometrial cancer or uterine sarcomas is abnormal bleeding, and that bleeding can be bleeding after menopause or bleeding between periods for women that are not yet menopausal. Any bleeding after menopause is abnormal. Any bleeding between the menstrual periods is abnormal. During the perimenopausal time, women's periods should space out and get shorter and lighter. They should never be becoming more frequent or heavier. Any of those symptoms should elicit, a conversation with your physician and further evaluation. Other symptoms that we can see that are indicative of or may be indicative of a cancer, we can see a change in vaginal discharge. Certainly every woman has a normal physiologic vaginal discharge that changes over a menstrual cycle in terms of its quality. A change outside of the normal in terms of the consistency or the color of discharge is worthwhile to report. Abdominal bloating. All women are going to have days where they feel bloated. You might eat something, you feel bloated. These symptoms are going to wax and wane day to day. That's normal, but symptoms that come and persist and get worse over the course of weeks to months necessitate further evaluation. A constant pelvic pain, any unexplained weight loss, changes in bowel function or bladder function, any abnormal finding on a self-exam, particularly of the vulva or the external genitalia, and then any itching, burning, or pain of the vulva are all symptoms that we can see associated with GYN cancers. The risk factors for these cancers are also disease dependent. And so we see different risk factors for endometrial cancer compared with ovarian cancer, compared with cervical or vaginal cancer. So for endometrial cancer, the most common risk factor is age. This is a disease of postmenopausal women typically, with a peak diagnosis between the age of 60 and 70. Endometrial cancer is strongly associated with obesity. We'll talk in a little bit. Endometrial cancer is one of few cancers that is increasing in incidence in the United States right now, largely driven by the obesity epidemic. And we know that for every 5-point increase in BMI, a patient is at 3 times the risk for developing endometrial cancer in their lifetime. And so obesity is a really important contributor to development of endometrial cancer. We also know that prolonged estrogen exposure in one's lifetime can increase the risk of endometrial cancer. And we can see that in women who start their periods very young or women that go through menopause later in life. Also, women with PCOS who may not ovulate and have a period once a month may have prolonged periods of estrogen exposure that increase that risk. We know that family history is associated with endometrial cancer. In particular, Lynch syndrome is a genetic mutation in one of 4 genes, also associated with colon cancer. And a diagnosis of Lynch syndrome will increase the risk above baseline. We'll talk a little bit more about that. We know that other diseases that may also be associated with obesity or metabolic syndrome, including diabetes or high blood pressure, will also increase the risk of endometrial cancer. The risks for ovarian cancer are much different. Largely, the large majority of ovarian cancers, about 85 to 90% of them, don't have a clear risk factor for diagnosis. We do know that age is associated with a peak incidence between age 55 and 60. But for ovarian cancer, a family history screening is critical. We know that patients with BRCA mutations, as Dr. Coopey referenced, are associated with a higher risk of ovarian cancer in association with breast cancer. And there are other genes that I like to refer to as BRCA-like, many of which Dr. Coopey referenced as well, that are associated with a higher risk of breast and ovarian cancer. And we'll talk a little bit more about those. Risk factors for cervical cancer and vulvar cancer are quite similar. So the large majority, about 99% of cervical cancers, are related to HPV exposure. The large majority of people that are sexually active in their lifetime will have been exposed to HPV. In some patients, the immune system will clear that HPV infection, and in others, HPV can progress on to precancerous and then a cancerous condition, typically with a period of about 20 years from HPV to diagnosis of cancer. Other risk factors include multiple sexual partners, smoking, and a weakened immune system. And we know that smoking itself weakens the immune system. There are other disease states like HIV or medications to treat things like rheumatoid arthritis, lupus, that suppress the immune system and increase the risk of cervical cancer as a result of that. There are 2 different types of vulvar cancer, and so the risk factors for vulvar cancer are variable depending on what type of vulvar cancer you have. About half of these cancers are associated with HPV, similar to cervical cancer, and therefore share similar risk factors. The other half are associated with an underlying skin condition called lichen sclerosus. We don't know why lichen sclerosus happens. We hypothesize that it may be an autoimmune disease itself. Patients with lichen sclerosis can have thinning of the skin, can have chronic itching or burning or irritation of the vulvar skin, which is why I say those symptoms are symptoms that should be reported to your physician, because lichen sclerosis can be treated with the hope of preventing a future vulvar cancer. But about 10 to 15% of patients with lichen sclerosis will go on to develop a vulvar cancer if not appropriately treated. In terms of screening for these cancers, the emphasis is on a well-woman exam and routine GYN care. So all women should have an annual exam with a gynecologist once a year, and that exam is different than a pap smear. And so I often have patients say to me, I don't need pap smears anymore. I've had a hysterectomy, or I don't need pap smears anymore. I'm beyond the age where pap smears are recommended. Therefore, I don't need to see a gynecologist. Those are two separate, two separate interventions that are not necessarily dependent on one another. So an annual exam should include both an internal and an external exam, because we see both internal and external GYN malignancies. This annual exam can be plus or minus a pap smear, depending on the patient. At this visit, you should be talking to your doctor about your menstrual pattern and keeping a good diary if there's any abnormalities in that. You'll want to review with your physician any risk factors for cancer, and then also your family history with consideration for genetic testing. And Dr. Coopey did a nice job outlining those indications for genetic testing based on family history. The decision for a pap smear is really based on specific guidelines that are outlined by an organization called the ASCCP. These pap smears are designed to detect cervical dysplasia, which is precancerous, as well as cervical cancer. And the interval of testing is dependent on a specific patient's history, their age, and can also include components of cytology, which is looking at the cells, as well as HPV, which is a DNA test to look for shed of that HPV virus. Beyond these routine well-woman exams, we do have considerations for other patients that are at high risk, such as those with BRCA mutations or Lynch syndrome. And these patients will often perform endometrial biopsies, which is a biopsy from the lining of the uterus. We'll consider a pelvic ultrasound to look at the ovaries, and we'll consider a blood test called the CA-125, which can be a marker for ovarian cancer in some women, but not all. In terms of prevention, the HPV vaccine is incredibly effective at preventing pre-invasive and invasive cervical cancer, as well as vulvar cancer. The current HPV vaccine protects against 9 different strains of HPV, which are associated with the highest risk of developing cervical and vulvar cancer. We also know that in some patients, birth control pills can be effective at preventing both endometrial cancer and ovarian cancer. In women that have used birth control pills for more than 5 years consecutively in their lifetime, it actually reduces the risk of ovarian cancer by about 50%. Other types of contraception, such as an intrauterine device, the trade name of Mirena or Kylena, those are progesterone releasing devices that can be placed inside of a uterus, often with the goal of contraception. Those help to prevent development of endometrial cancer and can be very effective for that. Tubal ligation or removal of the fallopian tubes, called a salpingectomy. There is data to support that both of these interventions reduce the risk of ovarian cancer by up to 50%. And in the highest risk populations, we talk about risk reducing surgery. So for women with a BRCA1 mutation, we know the risk of ovarian cancer is 40 to 60% over that patient's lifetime. And for those women, we typically recommend removal of the ovaries and fallopian tubes with or without the uterus by the age of 35 to 40 or at completion of childbearing. Women with BRCA2 mutations have a slightly lower risk of ovarian cancer in their lifetime, but still about 15 to 30%. To put that in context, the average woman walking the earth has a risk of ovarian cancer of about 1.5% in their lifetime. So we know that these mutations are associated with a significant increased risk. For women with a BRCA2 mutation, we recommend removal of the tubes and ovaries with or without the uterus by the age of 40 to 45. There are other mutations, these BRCA-like mutations, BRIP1, PALB2, RAD51C, and RAD51D, that are associated with a higher risk of ovarian cancer. And for those patients, we recommend surgery between the age of 45 and 50. For women with Lynch syndrome, and I've listed the genes there that are associated with Lynch syndrome, we typically recommend removal of the uterus as well as the tubes and ovaries between the age of 40 to 50. Lynch syndrome is associated with both an increased risk of endometrial cancer as well as ovarian cancer. And so for those patients, we recommend removal of all of the reproductive organs. In terms of lifestyle modification, we know that weight loss can play a really important role in reducing the risk of endometrial cancer. Weight loss is important to address from both a dietary modification as well as exercise. Dr. Coopey did a nice job reviewing those recommendations. And as I mentioned earlier, we know that for any 5-point increase in BMI, a woman's risk of endometrial cancer goes up 3 times. Smoking cessation should be encouraged. All of these cancers are at increased risk in women that smoke. In terms of our tools for treatment, just like breast cancer, we very much have a multidisciplinary approach to treatment of these cancers. Surgery is often a component of treatment for really all of these cancers. And surgery is performed by a GYN oncologist. We have a variety of surgical approaches depending on what type of cancer we're treating. On occasion, surgeries can be performed laparoscopically or robotically. For other types of cancers, for cancers at advanced stage, we may use a laparotomy incision, which is your classic open incision kind of up and down through the middle of the belly. For many of these cancers, systemic therapy is an important component of it. All GYN oncologists are trained not only in surgery, but also in chemotherapy. So you may work with a GYN oncologist that manages both the surgery component as well as the chemotherapy component of your care. On other occasions, we'll engage our medical oncology colleagues to prescribe the chemotherapy portion of treatment. Systemic therapy really has advanced greatly in the last 10 years. Classically, we think about chemotherapy, and there's a long list of chemotherapy drugs that are used. And the specifics of this, the selection of that chemotherapy regimen, is specific to each type of cancer. But we've seen huge advances in our approaches with immunotherapy, which we're using now in endometrial cancer, cervical cancer, and vulvar cancer. We have many hormonal approaches to therapy that we use in endometrial cancer and some ovarian cancers. And the latest advancement in the systemic therapy realm is antibody drug conjugates. And we're going to talk a little bit more about that at the end of this talk. And then, the last really essential component to management of GYN cancers is our radiation oncology colleagues have a huge role in treatment of endometrial cancer, cervical cancer, and vulvar cancer. So we talked that endometrial cancer is the most common GYN cancer. There will be about 60,000 new diagnoses each year, and this is increasing in frequency. The large majority of these cancers are diagnosed stage 1 because women present pretty early with postmenopausal bleeding or abnormal bleeding. Stage 1 cancers are typically managed with surgery, potentially with or without radiation therapy, and there's a couple different modalities of radiation therapy that we use. In terms of the surgery for this, a hysterectomy can often be performed robotically with removal of the uterus, cervix, and fallopian tubes. The decision whether or not to remove the ovaries is patient dependent, often driven by age. We also remove lymph nodes to assess the stage of this cancer. We've had some advancements in our surgical approaches with this, kind of following behind our colleagues in breast surgery, with removal of sentinel lymph nodes. So there's a picture there on the bottom left. With these surgeries, we inject a dye called ICG into the cervix, and then robotically, we use an infrared light to detect these green lymph nodes that look fluorescent under that light. And we can preferentially remove these lymph nodes, and we know that these techniques both reduce the morbidity, the side effects of the surgery, and increase the potential detection of spread to lymph nodes. And so this development has really changed the standard of care for surgeries for endometrial cancer. We know that robotic surgery itself is associated with shorter hospital stay, fewer complications, compared with our traditional open surgeries. At West Penn Hospital right now, we're enrolling in a clinical trial called Embrace GYN. This study is bringing our latest robotic surgery platform to hysterectomies. So this is a robot produced by Medtronic called the Hugo. It's the newest robot currently used in Europe and Australia, has been studied in prostate surgery and colorectal surgery in the United States. And our team at West Penn is one of 5 sites in the country participating in the evaluation of this technology in hysterectomies. This really is an advancement beyond our current technologies, looking at each robotic arm is on its own platform, really creates a very modular ability to, tailor each surgery and the placement of incisions to each patient. And on the left side shows the nice open air console so that the surgeon is actually feels more present in the room. Compared with some of our technologies currently. Ovarian cancer, this is less common than endometrial cancer, approximately 20 to 30,000 cases per year. With advancements in our treatment opportunities, patients are living longer with this. Unfortunately, in its earliest stages, many of these cancers are asymptomatic, and so it's not uncommon that these cancers are diagnosed at advanced stage. They require both surgery and chemotherapy, and our recommendations are for all patients with ovarian cancer that they should undergo genetic testing, just like women with breast cancer. In terms of cervical, vaginal, and vulvar cancer, many of these can be detected with routine exam and Pap testing. Results of a Pap smear often require more follow-up with additional exams and potentially biopsies. Some of these cancers can be diagnosed by self-exam, particularly those involving the external genitalia. And these cancers, really cervical, vaginal, and vulvar cancer are largely preventable with good Pap screening and vaccination. If these cancers do develop, they're typically treated with a combination of surgery and/or radiation. In terms of clinical trials, our group at AHN and GYN Oncology feels really strongly that clinical trials are the standard of care for our patients. What I've listed here, the specifics of these trials are not important, but all 3 of these trials have been practice-changing trials in GYN oncology and really developed the standard of care for these cancers as we know it today. The patients that enrolled on these clinical trials were the first to benefit from the advancements, from the scientific advancements of these studies. And so, when available, our team of GYN oncologists is actively talking to patients about enrollment in a clinical trial. To end our review of GYN oncology, I wanted to take just a minute to talk about antibody drug conjugates. These are our latest drugs to really change systemic therapy going forward. When we look at our historic chemotherapy options, chemotherapy in general kills cells that are dividing quickly without an ability to specifically target a cancer cell. And so What antibody drug conjugates do is they have designed a way to preferentially deliver chemotherapy agents to a cancer cell. And so you want to think about a cancer cell having a specific Lego on its surface. And what an antibody drug conjugate does is it links the chemotherapy drug to a similar Lego. And then that Lego on the chemotherapy drug goes around the body and it looks for similar Legos to bind to. And when you have that Lego on the cancer cell, but not on your normal cells, it preferentially delivers that chemotherapy molecule to the cancer cells. And what we see with this is that it really changes the side effect profile, making a lot of these agents much more tolerable and potentially also more effective. And so in GYN over the last couple of years, we've had a couple of antibody drug conjugates that are FDA approved in ovarian cancer and endometrial cancer. And the large majority of clinical trials that are in development right now are looking at antibody drug conjugates across these different disease sites. So that is all that I have. I think, Michelle, do we have some time for questions?
Sorry, I could not unmute myself there. Yes, our first question is, can you get endometrial cancer if you've had a total radical hysterectomy?
You cannot. No, you cannot, because with a radical hysterectomy, the uterus has been removed. And so you can't develop cancer at that point.
Okay, and our second question, if you were a year out after anal cancer from HPV and cancer-free at this time, are there any other preventive measures on screenings besides pap smears that you should have for ovarian or vulvar cancer? Prior pap smears were negative for HPV.
Yeah, so anal cancer is an interesting one because it's another often HPV-driven cancer, similar to cervix, vagina, and vulva. So we certainly do see some overlaps. For patients that have had anal cancer that have been fully treated and are beyond the age of 65, where we no longer recommend pap testing, we do not recommend any additional screening on the basis of anal cancer history alone.
Okay. Our next question. Do you have an increased risk of ovarian if you've had endometrial? And then in parentheses, it says no genetic mutation, but less than 50 years old.
No, not unless there's a genetic mutation that's driving that.
Okay. Our next question is, if you had one of the HPV shots but never completed the series 10 plus years ago, does this matter?
Yeah, so the answer to that is we don't know. We see about 70% immunity with a single vaccine and probably 90 to 95% immunity with two vaccines, and complete vaccination is 3. So there is likely partial immunity, but not complete with one.
Okay. And our next question, what if under 55 for HPV anal cancer? Not sure. Not sure of the question here. Maybe what are the risks if you're under 55 for HPV anal cancer, maybe? Are there risks for that?
So anal cancer, I guess I'm probably not the best person to answer that question. I don't know as much about anal cancer as some of our colorectal colleagues would. We don't recommend anal cancer screening with pap smear in the way we do cervical cancer screening. But many of the risk factors are the same between suppression of the immune system, smoking, multiple sexual partners, penetrative anal intercourse is also a risk factor for anal cancer.
Okay, and our next question, what can a woman do if they were being told your next PAP is 3 years out? Insurance drives this yearly push out. How can we fight that so that we can get one every year?
So that's a great question. You know, our guidelines from ASCCP for women that have had normal pap smears, if you're doing cytology alone, so that's just the pap smear without an HPV DNA test. If the cytology itself has been normal, the recommendation is for a pap smear every 3 years. If that pap has been done in combination with an HPV DNA test, the recommendation is actually for a pap smear every 5 years. And so that's not necessarily driven by insurance, that's driven by the ASCCP guidelines.
Okay, it looks like, are there any other questions? It looks like, oh, wait, there are a few more. Does polyposis increase the risk of gynae cancers?
So polyposis with a large number of polyps in the colon, if it's associated with Lynch syndrome, will increase the risk of GYN cancers. There are genetic mutations that cause polyposis that are not Lynch syndrome related, that do not increase the risk of GYN cancers.
Our next question is, why does brain fog / memory happen with bilateral mastectomy and aromic inhibitors? 1.5 years since surgery and medication. Is there anything we can do to improve this? Will this ever go away?
Hi, gosh, I know a lot of people experience brain fog with some of the aromatase inhibitors from chemotherapy. It generally gets better over time. I think there's definitely things that you can do to make it better in terms of like exercise, sleep habits. Some people go to cognitive behavioral therapy, you know, to help you like retrieve the information quicker, remember things quicker. But I know it's a little bit different for everybody. But I definitely think that there can be a benefit from cognitive like behavioral therapy, if you haven't tried that.
And I think we have time for one more question. If you've had endometrial cancer, what is the risk of getting breast cancer?
I think it all depends on things like genetic testing. If there's the presence of a gene mutation that puts you at risk for both. Most people that have endometrial cancer may have some of the same risk factors. Like there are some hormonal risk factors that overlap between the two, like age at first period, age at menopause, obesity, those sorts of things.
Yeah. I think with that one, you know, both endometrial cancer and breast cancer are very common cancers in women in the United States. And so it's not uncommon that we see patients that have both endometrial cancer and breast cancer, I think largely driven by those risk factors that Dr. Coopey mentioned, and less often driven by something genetic. We don't typically see a whole lot of overlap in genetic mutations causing those two particular cancers. They just are unfortunately common.
Okay, I have two more questions, and I think they're pretty good questions. I'll just speed up my closing if that's okay to get these in. Does multiple births increase the risk of gynae cancers?
We actually think that it's probably more protective than increasing the risk, because being pregnant and breastfeeding, if you choose to do so, actually shortens the interval of time that you're exposed to estrogen. You know, both breastfeeding and pregnancy are progesterone dominant states. And so the more you're living in those progesterone dominant states, the less likely we are to see those cancers.
Okay, and one last genetics question. Genetics consult pending after GR1A stage 1 endometrial ovarian cancer. I was told that there is a standard genetic panel that will probably be ordered. Anything else that's specific that I should request?
No, in my experience, the genetic counselors, that select the test are probably the most skilled folks we have at tailoring the test to a patient's history and their family history. In general, endometrioid ovarian cancers, particularly grade 1, are less likely to be genetic. But again, we recommend genetic testing for all ovarian cancer. Less likely to be genetic here, though.
Perfect. And I'm just going to wrap up one more question because I think it goes back to our multiple births increasing. This person's asking, am I more at risk for any of these because I have not and do not plan to have children?
The risk of endometrial cancer is higher in women that have never been pregnant.
Okay.
For breast cancer too, there's a slight increased risk for those who've never been pregnant.
That said, I wouldn't make that my driving factor in my decision whether or not to have children.
Perfect. Well, it looks like we have hit our 7 o'clock mark. I would like to thank Dr. Coopey and Dr. Miller for this wonderful discussion tonight and for your presentation. And we would like to thank everybody who attended tonight's Head of Cancer Lecture Series. As a reminder, tonight's lecture was recorded and will be uploaded to our YouTube channel in about 1 to 2 weeks. So look for it there. We'll see you next month. Thank you.
Thank you.
Bye-bye.
Bye.